Welcome to the Dr. Journal Club podcast, the show that goes under the hood of evidence-based integrative medicine. We review recent research articles, interview evidence-based medicine thought leaders, and discuss the challenges and opportunities of integrating evidence-based and integrative medicine. Continue your learning after the show at www.drjournalclub.com.
Please bear in mind that this is for educational and entertainment purposes only. Talk to your doctor before making any medical decisions, changes, etc. Everything we're talking about, that's to teach you guys stuff and have fun. We are not your doctors. Also, we would love to answer your specific questions. On drjournalclub.com, you can post questions and comments for specific videos, but go ahead and email us directly at josh@drjournalclub.com. That's josh@drjournalclub.com. Send us your listener questions and we will discuss it on our pod. Hello, everybody, and welcome to another Dr. Journal Club podcast with Adam and Josh. How are you, sir? How are you feeling, Adam?
I'm doing good, Josh. How are you? How's life? Any updates?
I'm a little frazzled. It was just like a rough parenting night last night, and I'm still kind of like reeling from it. But I will persevere, and it's like just ups and downs, man. Ups and downs with this stuff. Theo started school, and I feel like we're going through some behavioral transition issues.
Is he bringing home algebra homework, and you forgot how to do it all, and so you're struggling?
No, but I did definitely get like the digital eyebrow raise when I contacted his kindergarten teacher and was like, would you mind sending me the syllabus for Mandarin, because his tutor wants to correlate like what she's doing with his with his curriculum. It was like definitely like the digital eyebrow raise, and I'm like, whatever, it's fun, we like doing it together. So but now they're correlated despite the eyebrow raise. And yes, I realize how ridiculous that sounds when I say that out loud, but whatever. Anyway, so we will persevere. But today, we should do let's do another fun getting to know you thing, because I thought that was kind of fun last time.
Sure.
I'm open to anything, but I had this idea that, I don't know about you, I despise the icebreakers, like at conferences and things or at group sessions where it's like the sort of the standard icebreakers.
I think icebreakers in any situation are an awful idea.
Oh, they're just the worst.
Host an event and on your agenda is an icebreaker.
I squirm. When I see it. Yeah, I try to show up late just to avoid it. Yeah, no, it's terrible. And so I figured we would do that, and we just go through all the ridiculous icebreakers and just do it. So that's my idea. Do you have a better one?
Or we could just do life updates on a weekly basis.
Oh, okay. Yeah. Okay. So life updates. So Josh is struggling with kindergartenhood. How about you, Adam? What's a life update for you?
I've got a couple things. So I think, you and I have been talking about this for a while, but you and I are basically training for an Ironman.
Yes.
So we've just kind of been, putting in the miles and putting in the work, and it's been really fun to train with that. And so I'm in Portland, Oregon, and for those who don't know, there's a huge heat wave here, and like for the past week, it's been, over 100 degrees.
Whoa, really?
Yeah.
In Oregon?
Yep.
Wow.
Okay. Yeah, our summers can get actually pretty intense. So I know that sort of the Pacific Northwest gets this rap for being like rainy all the time, but it's just not the case. The rainy season definitely does exist, and it's kind of like November through March, maybe into May a little bit. But then like I love our summers because it's really dry, hot heat. But for the most part, it's actually like a pretty awesome environment to be in. But for this past week, it's been I think since Saturday or since Sunday, every day, and today is Thursday, every day has been above 100 degrees.
Wow.
And so the good thing about working in clinic all day is that,
air conditioning,
I'm not exposed to it. But yeah, and then in the morning and at night, it's like 75, 80 degrees, and you can feel it, but then during the actual daytime hours, it's really hot. So basically training for an Ironman, still kind of then not going to be a sprint Ironman right now, kind of training as though I'm doing an Olympic distance, but I want to do like an actual real Ironman. Not to say that not to discredit the other forms of an Ironman, but like the actual.
Well, we've got some time. So like you're training for an Olympic triathlon. Then our plan after that, right, is to do the 70.3, which is like a half Ironman, and then but like double. That's like double Olympic.
Mm-hmm.
And then I guess eventually, if we're not dead or eaten by sharks, we'll go for the full.
Yeah, exactly. Yeah.
So I might peace out after the 73. Just saying. I mean, I'm just putting that out there. That's pretty crazy.
We'll see how, if we get the bug or the itch to kind of.
I already have it, man. I was gonna do a sprint, and I was like, screw that. I'm doing international. Then I'm like, screw that. I'm doing Olympic. And now, I'm like, started talking to you, and you're like, oh man, we should just like do this thing. And I'm like, son of a gun, I really do want to do this thing. And so now we're like planning this 73. Anyway.
Yeah, so that's been fun to coordinate, and then in addition to that, I'm also moving across the country, so definitely not stressful trying to to sell my unit. And
where are you moving to, and why? Tell the listeners.
So I am moving to the state of Vermont for a job opportunity that came up that I could not pass up. It was everything that I kind of wanted from a career standpoint, and really, really excited for it, and happy to kind of divulge more information as I can. But I'm wrapping up my third year of residency and moving on to being an attending.
Yeah, that'd be nice.
So it's not going to be in an academic setting, but I'm really excited for what's to come, and to kind of help out that community that I'll be in, and looking really forward to it. But moving across the country while doing a 30 year of residency, while also trying to train for an Ironman, while also trying to have a social life, while also trying to work on Dr. Journal Club stuff is it's not stressful at all.
Yeah, well, plus I roped you into the forensics business too.
And my time management is perfect, and life is just unicorns and rainbows, and we're just farting out rainbows right now.
It's kind of how life feels right now.
Yeah.
Coffee in, rainbow farts out.
Exactly. I actually have an IV drip of coffee. I stopped with my oral administration from it. I peaked out on the concentration with that, so I just have a continuous IV of caffeine in me.
Yeah, I mean, it's I feel like there's a transition: coffee to espresso to no dose to IV drip, and it's it's just on that spectrum. It's funny. It's like there's just so much, and I think you and I are similar in this way. There's just so much I want to do with my life, and it's like there are so many hours in a day, and when everything was working well, I can keep all the balls in the air, and everything's fantastic, and I feel good, and I'm doing my runs, and I'm doing my bikes, and I'm doing my swims, and I'm being a decent parent, and all that jazz. And then you take one little thing, like a kindergartner, first week of kindergarten, or your sleep gets disrupted, or something like this, and then all of a sudden it's like you feel like it's at least I feel like it's crashing down, and I just need to be like, no, you're okay. Build it back up again. Anyway.
But yeah, anyway, so what are we going to talk about today?
All right. Well, now that we've bared our souls, so one of the things we love to do is to discuss articles or questions that listeners have. So one of my colleagues reached out to me about the use of glutamine in IBS. It was somewhat new to her, at least at the dosing that I was talking about. And she was like, "Oh, cool!" Like, and I love this. It's like, "Oh, do you have a study?" Which I was like, "Oh, yes, I do. That's perfect." So, I thought we would talk about that. It's relatively recent, 2019, so 4 years old, but it's a pretty well reported, well done study, in my opinion. And we'll put a link in the show notes. But one of the good things too is I haven't looked at this deeply for a number of years now. Like I kind of read it; it got incorporated into my clinical practice. Based on my assessment of it. And then it's like one of those things that's always good to revisit so you have it in front of mind. So I maybe spent 7 minutes reviewing it quickly before the call. And Adam, because his life's just as crazy, if not crazier than mine, didn't have a chance to read it. And I think that's actually kind of good because I think we can model what it's like, what we look for when we're fresh. Like we haven't prepared. So if a listener like just pulls a study, what are the first things they look for as they walk through it? And so I feel like it'll be useful in that regard. Like we won't be over prepared, if you will. So why don't we instead of presenting it, Adam, I was thinking instead of like presenting it like a presentation, like let's actually just kind of go through it as we would with fresh eyes.
Sure.
And kind of be like, okay, we've done this before. Like, what would we look for? What are we looking for here? I always love those. I think it's more useful to listeners than like an over prepared presentation. What do you think?
Yeah, let's do it. Let's go right into it.
Okay, cool. So, all right. So I'm pulling up the study here, and I'll just tell you what I'm thinking. So the first thing I'm glancing at here is the journal. So it's journal Gut, which is a very good journal for gut related stuff. So first of all, let me just read the name of the trial so people know what we're talking about. It's a randomized placebo-controlled trial of dietary glutamine supplements for post-infectious irritable bowel syndrome. So using glutamine in IBS patients, specifically post-infectious IBS. And so I say, okay, cool. Quickly glance at the journal. It's in the journal Gut. That's a good journal. That's sort of a plus. You have to be cautious because, just because things are published in good journals doesn't mean they're great. And just because they're published in not so good journals doesn't mean they're bad. It's just sort of like the first thing I notice. And then the second thing I look at, besides maybe glancing at the journal, is the author list, particularly to see if I recognize any of the researchers, which I don't. And then to kind of glance at their affiliations, which and that's for me, that's a red flag search real quick to see about industry sponsorship. So whenever I see a supplement study or a pharmacy study, the first thing I want to make sure is that this isn't essentially funded or secretly funded by the company making the product. And I don't see,
if it's not in the front, it's at the end, kind of like
very good.
at the end
Yep.
of where the references are. Most journals kind of do kind of house it there, but if it's not in the front, look at the back.
Excellent, indeed, and that's indeed the case here. So first thing I'd say is eyeball the affiliations, make sure they're all academic and there's no red flags as far as, it's with a certain company and then you have to Google search if they make that product or not. So that's one check, and then the other check, like Adam said, is go find the conflicts of interest statement. And it's usually either beginning or the end, just like Adam said. And this one, if you go to the acknowledgments on the last page, it's sort of buried in there. They make some acknowledgments, but then they also say the authors have no competing interests, and it's funded by NIH, the National Institute of Health, and the Department of Veteran Affairs. And so it looks like all the funding came from government sources. There's no commercial conflicts that we can tell, and they've registered the trial at clinicaltrials.gov. So those are the first things that I look at. Adam, anything else on your first glance that you look for in a study?
No, that's typically it. Excuse me. And then also, if you really want to kind of dive down, you can go into the actual clinical registry just to make sure that what they did is actually what they said they were going to do a priori, meaning before they did this study, making sure that what they published is consistent with what they said they were going to do.
Exactly. And that's essential for selective outcome reporting bias in particular, as well as a few others, where basically the authors are like, well, before we saw the data, we thought we were going to look at X, but now we're just going to report Y because it looks better. And so that's the whole point of a priori registration. So you can kind of check that. So it's good to see that they registered it. But just like Adam said, if you smelled anything fishy or you thought there were any red flags or you had some extra time on your hands, you go to clinicaltrials.gov and kind of track down the outcomes and the statistical plan they said they were going to do and then compare that to what they report. So excellent. Perfect.
And I think building
Mm-hmm.
off the industry sponsorship, if they are sort of funded by industry, see exactly what that funding is going to. Or is that company just providing the product? Are they actually, having a decision on whether or not this is going to be published or not? If they're being transparent, they won't hide anything. So sometimes you'll see a study that is, industry sponsored, but they'll say, hey, all we did was just give free medication or free supplements. We have some authors who, they do have some. They do receive some funding for, let's say, going to conferences and promoting our medication or our supplement, but for this purpose of this manuscript actually had no conflict of interest, and they had the ultimate decision to publish. Maybe we were involved in the methods and whatnot, but ultimately, at the end of the day, everything is transparent and truthful via the authors.
Yeah, that's perfect. So we've talked about this before, and we've got a bunch of publication bias videos on Dr. Journal Club, the mothership. But I would fully agree that just because it's industry sponsored doesn't mean the methods are bad, doesn't mean that there is actually bias. There has to be a mechanism of that bias. But the way I've been thinking more and more about how a clinician should read a paper is with a red flag approach.
Yeah.
And so the first red flag, I think, is to sort of just quickly get a sense of if it's industry. Now, if it's industry sponsorship, to me, that's a red flag. That means just look deeper. Doesn't mean it's
Yeah.
bad. It just means look deeper. If you don't see any of those flags, then, busy clinician, I feel like, can move on.
I would say,
Yeah.
however, if you're seeing like multiple red flags,
Yeah.
and it's starting to look really iffy, you can just stop. You don't have to keep reading and feel like you have to finish the whole study. If there's a
Yeah.
lot of red flags, it's not a good study. The results are not going to really be, valid from that standpoint, and you can just toss it and move on.
Yeah. Agree. So next thing I do is if I'm actually reading the paper and not skimming, I usually actually do skip the abstract and kind of move into the introduction. And I guess what I look for in the introduction, a good introduction, is to give me a general sense of what the background literature currently says, like a quick catch up on what the literature is and the rationale for this setup. And that's kind of really all I'm looking for. And hopefully by the end of it, I get a sense of, okay, like for example, there has been some connection with glutamine and different types of IBS, and gut cells, can be damaged with different types of IBS, and glutamine is a major food source for gut cells. So it sort of sets up that rationale and the current evidence base. And then it sort of sets you up to say, okay, now we're going to tell you about the trial. Now that you understand the potential mechanism and the background information, and then we go from there. So I'm usually just skimming that pretty quickly just to make sure I understand what the foundation is leading into the trial. How about you?
I almost always skip the abstract unless I can't actually access the paper and I need something like now. But if I do have access to the full paper, I always skip the abstract because I don't want that to kind of bias my way going into it. And so I'll read everything and then look at the abstract at the end and kind of see, okay, are these what they're promoting actually what the study showed, or are they kind of hyperinflating the results to kind of spin it in a different lens? Because then I kind of view that as a red flag. And
Good.
then depending on what the topic is, so my master's thesis was IBS related, so I'm very well versed in the background literature. So things that I'm well versed in or feel comfortable with, I almost always skip the entire introduction, don't even bother with it until I get to the very end, where it's usually the case where the last 1 to 2 sentences tell you what the study's actually about, and that's the case in this study, where the very last sentence is exactly what the study is going to be. In what they're doing. And so I didn't even bother with the introduction because it's on IBSD, and that was part of my master's thesis. And so I feel very well versed in all that information.
Yeah, I think that's perfect. The purpose really is to set the stage, and if you kind of know the stage, you can skip to that last objective sentence or aim sentence. Sometimes people call it. Yeah, totally. And so just to set the stage for listeners, in case you aren't IBS geeks like me and Adam, essentially the rationale is so IBS is super common. Depending on which study you're looking at, maybe 1 in 10, 1 in 15, 1 in 7 people probably meet criteria. There is a new Rome guidance. IBS is usually diagnosed via the Rome criteria. Rome 4 is stricter than the others. You actually have to have abdominal pain, not just discomfort. There are different forms of IBS or causes. IBS is just basically diagnosed by, do you meet these criteria, these signs and symptoms? And if yes, you've got IBS. If not, you don't. And there's no mechanism part of that definition. So the way I like to describe IBS to patients is, there's probably 15 different causes of symptoms that would put you in this category. And, if we're doing good root cause medicine, we're addressing that, not just addressing the IBS symptoms. That's how I look at it. So one of the buckets of IBS is post-infectious IBS. Maybe about 10% or so we think, something like that. And essentially, you get a gut infection, and then you start developing IBS-like symptoms afterwards. And that is surprisingly common, this post-infectious IBS mechanism. So that's specifically what they're looking at. And their rationale is, so it's not just that. So we're looking at a subset of IBS-D, so IBS with diarrhea, that is post-infectious in nature. And we can talk about how they define that in a second. And they're interested in leaky gut, or what they call intestinal hyperpermeability, which is the fancy word for it. In the lay media, people will often say leaky gut, but in the research literature, it's intestinal hyperpermeability, because of course the intestines should be permeable, but if they're more permeable or hyperpermeable, that's when you get the problems associated with it. So that's what they're looking at, and the rationale is glutamine. There is data that glutamine can help patch that up, and there's also mechanistic arguments for how an infection could mess that up, and that sort of sets the stage for the study. Any questions before we jump into the methods, Adam?
No, I think that's great. Let's keep on rolling.
Look, the thing is, we don't do this for money. This is pro bono, and quite honestly, the mothership kind of ekes it out every month or so, right? So we do this because we care about this. We think it's important. We think that integrating evidence-based medicine and integrative medicine is essential, and there just aren't other resources out there. The moment we find something that does it better, we'll probably drop it. We're busy folks. But right now, this is what's out there. Unfortunately, that's it. And so we're going to keep on fighting that good fight. And if you believe in that, if you believe in intellectual honesty in the profession, in integrative medicine, and being an integrative provider and bringing that into the integrative space, please help us. And you can help us by becoming a member on Dr. Journal Club. If you're in need of continuing education credits, take our NANCIAC approved courses. We have ethics courses, pharmacy courses, general courses. Interact with us on social media, listen to the podcast, rate our podcast, tell your friends. These are all ways that you can sort of help support the cause. All right, so now we'll go into so now we've got the stage. Now we'll kind of look at the method section. Before we jump in, anything in particular you look for in methods in general when you're scanning a paper for the first time?
Well, I would say that this is the most important part of the entire paper, because it's telling you not only what they did, but who the patient population is. So, do the people who are going to be involved in this trial, consistent with the patient population that you're going to see? Because if you're a urologist and this is a paper on, cardiovascular outcomes, then, it doesn't really apply to you. And so this is on, post-infectious IBS. So we can't really apply, IBS-C, IBS with dominant constipation symptoms with these results. So you can't really take this and run with it and tell all of your IBS patients, hey, use glutamine or don't use glutamine. It's really for those that you're pretty confident have IBS with diarrhea as the predominating symptom. And then also, you need to look at, okay, how do they define certain inclusion criteria? How do they define certain outcomes? So when they say, an improvement in GI symptoms, what does that mean? Is it improvement in abdominal pain? Is it improvement in stool form? Is it improvement in stool frequency? Is it complete resolution of symptoms? Is it some sort of hard outcome, meaning, in this case of cardiovascular disease, did we prevent a heart attack? Or is it some sort of surrogate outcome? Did we just improve maybe their cholesterol panel, but they still got a heart attack? Did we improve their IBS questionnaires, but they're still having significant symptoms? So those are kind of the things that I'm looking at. Who did they include? Who did they not include? Looking at more sort of the nerdy methodology. Okay, they said that they randomized. How did they randomize? Was the randomization adequately done? Was it truly random or not? How do they run their statistical analyses? Now, I think as clinicians, most can kind of skip over or gloss over the statistical analysis, but there's some things that if it's a good study, we'll typically report that you should be aware of. So something like an intention to treat analysis is something that you want to look out for. If they're saying that they're blinding, okay, how are they blinding? Who are they blinding? Et cetera, et cetera.
Love it. Yep. Perfect. I think that's all great. And agree to all of that. So let's jump into some of the methods, things that I pulled out when I was eyeballing it, which again, I think is an advantage for our listeners here. So the first thing is we're looking at eligibility criteria, and they define IBS by the Rome 3 criteria. So this study is a little bit older, and the recruitment period was back in, I think, 2011 or something like that when they started the study. And back then, we just had Rome 3. I think Rome 4 came out in 2016 or something like that. And so it kind of makes sense that they would use the most recent Rome. Now, just as an aside, I actually prefer that because Rome 3 is less strict than Rome 4 because it allows for quote unquote discomfort as opposed to pain specifically. And that, in my patient population, I just see a lot of people that suffer from gut related symptoms that may or may not say, well, it's more of a discomfort than a pain thing. And I feel like there's still utility in that. So these are the patients that, like Adam said, like what are the patients in what is the patient population here? So that's what we're talking about. So people that have gut related symptoms that are related to, bowel consistency or bowel frequency that either gets better or worse around that basically is modified by the stools, and they report discomfort or pain. That's kind of the Rome 3 criteria there. Also, they looked for intestinal permeability. They use the lactulose mannitol test, which is sort of the standard in the research community and also is available clinically, which I love. I do use it on occasion because I like that you can get a relatively cheap test that tests just like we do in research. And just super quick, essentially the idea is you consume two sugars. One is should be absorbed through the intestinal lining. One should not. Lactulose should not be absorbed. Mannitol should. And then you basically measure the amounts in the urine. And the theory is if your intestines are intact, then the lactulose is going to just sort of go through the pipe and come out in your poop. If it's not intact, then it's going to get through the cell walls, the intestinal lining walls, get absorbed, get through the bloodstream, and eventually you're going to pee it out. And you're going to see it, and you're going to compare it to mannitol to get a sense of kidney functionality and all that, to get a ratio. And if it looks like there's too much lactulose in the urine, then it's like, okay, there's leakiness here, and you can sort of quantify it as well. So that's how that was defined. Also important to look at, as Adam said, what the patient population is like is the exclusion criteria. And I think what might be relevant here is they excluded people with bacterial overgrowth. So that's SIBO, small intestinal bacterial overgrowth. And they also excluded people who were taking glutamine. So that makes sense because we want to test that out. We want people naive to glutamine. And also who were taking whey protein. And that kind of had me scratching my head until I later looked and realized that they used whey protein as the placebo. So basically, they wanted people naive to both the intervention and to the placebo. Okay, cool. Any comments on that?
Yeah, I think something that was interesting was that they actually didn't confirm that they had post-infectious IBS. It was just in their medical chart. So they said that stool cultures were not confirmed or not obtained, excuse me. And so, I don't know. I think that's kind of interesting.
Yeah, it is. It's also extremely common in practice. And because essentially you'll have gut infections that will be very transient, maybe a couple days. And by the time, people get to the doctor, they may or may not get a stool test. That's super common. And usually and also, of course, IBS doesn't develop until months later in post-infectious IBS. So clinically, the way this happens is a patient will present to the doctor and be like, yeah, for the past 9 months, I've been, having all these symptoms. I never used to have it before. You ask about the background. It's like, well, a couple months before I started having these symptoms, went abroad and I, ate some sketchy stuff and I felt sick for a couple days and then I got better and I just felt like it was Montezuma's revenge and I just moved on. Right. That's sort of the classic story. And usually that's good enough for a clinical diagnosis of post-infectious IBS. There are blood tests for it available now, where you can actually look at anti-vinculin and anti-CDTB, which are antibody markers for post-infectious IBS. So if you wanted to get fancy, you could look at that, and they do stick around. And so that is a possibility. I don't know that clinically it's always useful, and it was not available back when this study was done. It was more recently developed and released commercially.
Awesome.
Cool. All right. So let's jump in. So baseline testing super quickly. So they talk about using the lactulose mannitol test. They talk about how they tested for SIBO, all of which is very standard. No red flags there. They did do so for outcome measures, they used the IBS SSS scale, or the IBS SS scale, or IBS SSS. And do you want to, are you familiar with that one?
Yes, the IBS symptom severity scale. So basically, it's a questionnaire that kind of asks central domains. So you have separate categories, and then within those categories, you're going to have subcategories, kind of asking you about your questions. And the greater the score, the worse the symptoms.
Yes, and I would say it's very common to see this in research. It's a very common scale, and it's also very well validated. And what's useful to us is there's a very well established minimal important difference, of which we are obsessed. And I recently gave a talk on minimal important differences. I think we'll probably release it in Dr. Journal Club in the next few months or so. That's what I spoke on at Pi, was minimal important differences, that sort of fascinating topic. But we got a bunch of videos on Journal Club now. We'll eventually have continuing education videos on that as well. But essentially, it's like finding a threshold that actually matters to a patient. And so for the IBS SSS, we have a very well established MID, minimal important difference, of 50 points. It's a 500-point scale. So if you can, if you come in, higher numbers are worse. So if you come in, so let's say your baseline is like 200 points, and then you drop, or the average of the population drops to 150, you would consider that difference clinically meaningful or minimally important for a patient. So that's the other thing. And then they look at other outcome measures too, like stool consistency, frequency, and then permeability changes as well. All very reasonable to me. Let's move on to randomization. So you had mentioned randomization before. What are you looking for? What are the triggering words that you're looking for, or what do they call it? Signposting, I think, or guideposting. I can't remember the phrase, but what are you looking for when you look at randomization?
Yeah, so I'm looking to see, is it computer generated? Was the person who did the randomization blinded? Sometimes you'll see like opaque envelopes, which is usually a good sign, because it means that not only did they randomize it, but then the people who are instructing the participants to go into either group are truly blinded and don't know who's going into what. Because if you randomize, and then let's say you're able to look at the participant list and kind of know where people are going, that kind of defeats the whole purpose of not only the blinding but the whole point of randomization. And so those are kind of the main things that you're looking for, sort of like a central randomization location, seeing if randomization was done by some sort of independent person. It's usually some sort of a statistician. Those are kind of the things that I'm looking for. Because if even though some things may sound random, like, oh, we'll take everyone with a blue hat, we'll get the treatment, and everyone without that will go into control. It's not really random, because then you know kind of who's going into which group. So that's kind of this idea of pseudo like randomization. But what you want to look for is computer generated, or anything that like is truly random. If you were to put like paper in a hat and just kind of mix it around, that is actually technically valid.
Yep. So basically, just like you said, and no way to mess up that randomization. And I agree. I think the code words you're looking for is computer generated, and we have that here. So randomization was done using a central computer-based automated sequence. So that would get a green check mark for me for that one. And then the next thing, and this is less important, and I've been de-emphasizing this in teaching clinicians over the years, but like you said, allocation concealment, and that is you make a randomization order. That's the randomization part, but then the list, if you will, the allocation needs to be hidden as well. And the theory is that people that are giving the bottles out may choose, oh, you look a little bit healthier, so I'm going to give you this bottle because I know this bottle has the stuff, and you look sicker, so I'm going to give that to you. And whether that happens consciously or subconsciously, we have empiric evidence that happens. And for that reason, you have to, like you said, opaque envelopes sort of to hide that allocation, because you can have a perfect randomization sequence, but if it's compromised before it even gets to the patient, that's a problem. And so code words to look for, like you said, is opaque envelopes. Also what they have here, so the random assignment order was created using consecutively numbered study drug containers. Patient and study investigators were unaware of the study group assignments. So essentially, you had this randomization, and then you had this printout of sequential numbers, meaning patient 1, 2, 3, 4, 5, 6, 7, 8 gets these bottles, and there's no chance for the study nurse or the study assistant to select the next patient that walks in the door who gets what bottle. It's like, oh, you're the next patient. You, and the one before you was number 10. You get bottle number 11, and that's another way to protect it as well. So I would say that that's also a green check mark there. Good. Any further comments on that one?
Nope.
Okay, sweet. Moving on here, we're doing good. Again, I think this was a pretty well-reported study, so there's not a lot of question marks in my mind about how they did stuff. So people basically recorded their IBS SSS scores. It was an 8-week trial, and they got glutamine 5 grams 3 times a day, which is what I use clinically now based on this study. And so basically they gave them, or whey protein, sort of equivalent pills. And then they measured their stool consistency, et cetera. And then at the end of the study, they had them do their IBS SSS scale, and they redid the intestinal permeability. And this was an 8-week study. Now, one of the next things I look for is the outcomes that they say they care about. And again, the more outcomes you look at, the more chance of like p-hacking and just randomly seeing something positive by random chance. And that's why it's important to clarify what your primary outcome of interest is and what's secondary. And they very clearly say their primary outcome of interest is the IBS SSS scale, specifically going over 50-part improvement. In other words, an MID, minimal important difference on that scale. So I like that. And then secondary outcomes were everything else we've been talking about. Any comments on that one?
Nope.
Okay, cool. So far, so good. We kind of know what we're looking for and know how they set it up. And then let's jump into the study here.
Well, before we get into that, I
Mhm.
think one thing in particular to this study, only patients who completed the 8 weeks were included in the final data analysis. So it sounds like maybe an intention to treat was not done. Do you want to talk about that?
Yeah, so that's really, really excellent point. And there's a lot of confusion because they'll say there was no loss to follow up, but then the way they reported that. So actually, this is a great idea. Let's take a few minutes here. Can you talk a little bit about what we're looking for here, what the issues could be?
Yeah, so they're kind of doing what's known as a per protocol, at least based on just that one sentence of only patients who completed the trial were included. Meaning, if we wanted to look at the results of a study, we could either evaluate the data based on only people who completed it as it was supposed to be intended. So only people who took the medication exactly as prescribed, they followed up, they did everything that we asked to kind of understand the quote unquote like true effects of the intervention. The other alternative is, hey, we just kind of, once we've randomized everyone is included in the data. Doesn't matter if they walked outside right after the study and got hit by a bus, or if they did everything that we asked and we completed it. And the good thing about the intention to treat is it's more reflective of a real world sort of way of kind of analyzing the data, because we will give patients treatments, but not everyone will take them exactly as prescribed. They may miss a dose, they may go on vacation and forget about doing something for a week, or they never follow up with you. In research, we call that loss to follow up. And so, it's a little bit more reflective of the real world. And also something that comes up is with a per protocol analysis is if you're only having people who've completed the study as it was actually instructed to do so, you may be biasing the results a little bit, because the baseline differences you may then notice a change in the baseline difference, and we may kind of ignore why we're having dropouts to the study, whereas the intention to treat preserves that entire randomization.
Yeah, beautiful. I think that's super good. And if you're following along with the study, it's on page 12. So what you're looking for here to get a good sense of the study flow is the study flow diagram, sometimes called the consort diagram. Here, that's on page 12. It's figure 1. It's usually figure 1. And essentially, we see 115 people underwent randomization. 59 were assigned glutamine. 56 were assigned placebo. 5 of the glutamine people stopped the glutamine. 4 of the placebo people stopped the placebo. But who was analyzed? That's the question that Adam's asking. And they just analyzed the people that stayed on the glutamine. So instead of 59 who were allocated to it, it was 54. And same with the placebo. Instead of 56 people with placebo, 52 were included because they excluded the people who discontinued the placebo. So yeah, I think Adam nailed the advantages and disadvantages of intention to treat or per protocol. So I think that's excellent. We also have a lot more videos and training on that on the mothership if you want to learn more. And yeah, I think that is an important point. Excellent. Okay, cool. So jumping in here, adherence rate was pretty good. Even with those dropouts, it was over 90%. And it was equal, which is important. Why would it be important that dropouts were essentially small and equivalent across groups?
Yeah, because if we have large dropouts, especially if there's a big discrepancy, we want to know, okay, was it actually the treatment that was really not tolerable, even if it was efficacious? That's kind of the main gist of it, is understanding, okay, why are we having these dropouts? Is it just not feasible? Is it too difficult to do? Are the side effects too great? And so, we just want to make sure that we have as much data as possible. If we have anything that's above, typically the cutoff is like what, 15 to 20% of
Yeah.
dropouts. That's when we start to get really concerned about
Yep.
sort of the veracity of the data.
Yeah, exactly. And I would add too, so everything you just said about the tolerability, but also you want to make sure that randomization is kept sacred. So, or the prognostic factors are kept sacred. So the purpose of randomization is to balance known and unknown prognostic factors. And if any of that is messed with, you're in trouble. You lose the benefits of randomization. So if, for example, they're like, yeah, it's a blinded study, but 30 people dropped out in the glutamine group and 2 people dropped out in the placebo group. Well, this like, well, whoa, like what's going on here? So A, tolerability, right? Glutamine might be intolerable. B, it could be that you're basically losing the people that didn't respond to glutamine, and therefore you're biasing your result because you're biasing your negatives. They could have dropped it because it wasn't helping. Or it could be so, the side effects could be so high that they suspect that it's happening and they get unmasked essentially, right? They're like, well, I must have got, because they know they're either getting placebo or the real deal. And they're like, I must be getting the real deal because I'm having all these symptoms, right? So those are the things you're looking for. So for tolerability, you look at the overall amounts, but also if it's really unbalanced, you have to ask yourself questions about, is the blinding masked? Have you excluded people that are just non-responders, like the non-responders dropped out and then you just exclude them, and so of course it's going to look rosy at the end of the day, right? So you have to be particularly careful about that when you're doing a per protocol analysis where you're excluding them from the analysis.
Yeah,
Excellent.
and I
Mhm.
think too, to know if sort of the randomization quote unquote worked, is look at the baseline demographic table.
Mhm.
And if there's very like minimal differences between the two groups, and especially if they're not statistically significant, then you can say that randomization quote unquote worked. Now you're going to have a little bit of variance. Maybe one group had like 28% versus like 33% of, let's say, some sort of, let's say, abdominal bloating. Now, although that's a nominal difference, so there is a difference there from a number standpoint, is that actually clinically meaningful? Is it statistically significantly different? Or is it just kind of background noise? Most of the time, if randomization works, you can get almost identical background demographics, but sometimes here or there, you'll see a little bit of discrepancy, but it's how much or to what extent does that discrepancy actually matter?
Yeah, excellent. And I would add there is a little bit of controversy about p values in those tables.
Hmm.
So, like you said, you want to eyeball it and make sure things are essentially equivalent. But you're usually looking at 20, 30 elements. And so by random chance, you might just have things that are statistically significantly different. And that doesn't mean that the randomization is bad. In fact, some people don't even run p values on those tables for that reason. And then the other thing is that measures for known prognostic predictors, right? Or prognostic variables like age, BMI, stuff like that, severity of IBS. It's the unknown that we're also concerned about. And that's why we still do the randomization. And then the last note there, and I think we had this in one of the last papers we read, was if you really are sure that there are a few very important things like age or baseline severity, you can do basically a type of randomization, block randomization, permuted blocks for something like that, where essentially you get the benefits of randomization, but you ensure that these really important variables are balanced across groups. You don't just rely on the random chance. And that's important, especially in smaller trials where the rule of large numbers doesn't necessarily apply. So good. Okay. All right. So let's look at the actual results.
Well, before we get into
Yeah.
that, sorry.
Yeah.
Before we actually get into the results, I think it's also important to recognize that you have to know what the study is most interested in analyzing,
Mhm.
because if they're like, hey, we want to see if the diarrhea resolves, but then they report on 400 different outcomes, we have to remember that the study is actually meant for that one outcome. So let's say the primary outcome, let's say, was improvement in the IBS scores, and the score only improved by, let's say, 5 points, which isn't clinically meaningful, but maybe there was something else that was considered to be statistically significant and they focus in on that. That's a red flag. We also have to recognize that usually the primary outcome in most instances is really all that kind of matters from a study standpoint, and everything else is more of just like, oh, that's interesting, we should probably look into that further. But take those results with a grain of salt. If the main thing that they're interested in doesn't show benefit, that's kind of really the take home, and everything else is kind of just noise and stuff to kind of think about and look into and be interested by. But you can't just kind of run away with it and say, oh, they did find this one thing, and so therefore now we should use it for that one thing. Because every time you run a statistical analysis, you increase the risk that that significant finding is just due to chance, right? So let's say when a p-value is set to 0.05, you're essentially saying, hey, if we find anything statistically significant, there's a 5% chance that this is just due to, let's say, sheer luck. And so if you keep repeating that, every test has this 5% chance, chances are you're going to find something. So it kind of compounds on that. And so, you might just find something by accident, whereas that primary outcome is really the main thing that you should be focusing in on. And we'll leave it at that.
Yeah, I think that's great. And from the clinician, code words to look for there are, primary outcome, registration, and then, yeah, just like Adam said, looking for that spin would be a red flag. So here, things are looking pretty kosher. They said, very clearly stated their primary outcome was this minimal important difference on this well-known scale. We didn't check the registration. That could be one extra level to go back to the registration and make sure they said that was what they cared about at the beginning. But it certainly seems reasonable. That would be what I would pick, for example, IBSS scale and using an MID of 50 points. And so this is what they found. So these are people that improved at least by the amount that we think matters to patients.
So
We
at least
have
50 points.
by at least 50 points on this 500-point scale. This is almost 80% of the glutamine group, so 43 of 54 patients met that threshold or better at the end of treatment, versus the only 3 of 52 patients, or about 6%, met that minimal important difference with a very statistically significant p-value, 0.001 or less than, not surprising because of that strong difference, a 14-fold difference. So 80% versus 6%. So essentially a very robust effect size, not surprisingly, very statistically significant as well. And we basically say, okay, if you have IBSD that is post-infectious in nature, we clinically suspect that, and you give the patient glutamine, 5 grams TID for 3 times a day for 8 weeks, we would expect, based on this, about 80% of people to report that they improved at least to a minimal level that matters to them, as opposed to only 6 if you gave them a placebo there. Awesome. Then looking at their secondary outcomes, the bowel movement frequency improved, stool form improved as well, and intestinal hyperpermeability improved too. And what I think was very interesting was they then correlated the improvement in intestinal permeability to the improvements on the IBSS scale. And what they found was that they correlated pretty well. In other words, that as the people who improved the most on permeability improved the most on symptoms. So this was sort of more of a mechanistic argument to say, yes, it certainly seems to help, and we think it's the mechanism we suspected, which is improving hyperpermeability, seems to be connected to that symptom improvement as well. Now, one of the other things that I think was interesting, like a question mark, was, the whey protein placebo. And a lot of people would argue that whey could be triggering for a lot of people. And so one of the potential issues could be that if the placebo group got worse because of the whey and the glutamine group just didn't do any better, then the difference that you would see between groups could have been just because the placebo was like a nocebo or had a negative effect instead of being null. But they did look at that, and they said that actually it looks like the placebo group stayed very stable. They didn't get worse, whereas the glutamine group did improve over a baseline. So that looks like that's pretty good as well.
And I think something that's really helpful in this case is that by doing that correlation with the biomarkers,
Mm-hmm.
we have plausibility to the truthfulness of our results. It's not
Yes.
just like, it's not sort of like it's not kind of like a placebo effect with the glutamine. We have, mechanistic data within a clinical trial that supports the benefit from a physiology standpoint, which is encouraging.
Yep. I love it. Yep. Very, very good. Yeah. And that's pretty much the study. I think big picture for me, it was a good study, well designed, well reported. Probably biggest limitation is the study size. And so from that perspective, you would expect a lot of, imprecision around that estimate. So it may not be as high as 80%.
And then, Josh, do you ever read the discussion or conclusion section, or do you just skip over that?
Yeah, I usually skip over it. I think that's where a lot of spin happens.
Mm-hmm.
Even if it's not industry sponsored, authors, we're incentivized, and I'm guilty of this as well. We're incentivized to basically say that everything we do is going to change the world, especially if we're writing grants. And so there was some really funny translations that I saw as going around on a Twitter meme, which was or an X meme, which was essentially like, this has never been, we gotta post it or something. It's like, this has never been studied before. This is novel. This novel approach basically translates to this very unique, specific intervention, which is really somewhat meaningless to most people, has never been done before. And so sort of those translations. So I would read these discussions and introductions, those types of language, with a grain of salt, and really just kind of stick to the meat of the study. But yeah, the discussion can sometimes very helpfully explain. If a good discussion should explain how these results fit within the larger evidence base and sort of interesting things that pop out of it. You just have to be careful of overinterpretation
Mm-hmm.
and spin there, I would say.
Yeah, because sometimes you get like an absolute negative trial of like this
Mm-hmm.
clearly did not work and you
Yeah.
could not move forward with this intervention. And then in the discussion section, they'll be like, well, here's probably why it didn't work. If we were to do more trials and we did this and that, then oh, this one, we did find this one statistically significant result that was not actually something that we were, really interested in. So that we have something there that needs to be explored. So it is possible that this, could be important, and then they may report that within their abstract. And so then, if you're not actually paying attention to what you're reading, you can kind of be hoodwinked.
Yeah, I think that's great. One thing I did want to add was applicability, and I know we have to get off in about 5 minutes, but so I wanted to add a little bit of nuance to what you said, and maybe you disagree. Maybe it's not a nuance. Maybe it's a disagreement, which is when the way I look at evidence-based medicine is you take sort of like the original definition. You take best available evidence. So let's say that's this. You take patient values and preferences and physician experience, and expertise, and that confluence is evidence-based medicine. And so I would say a lot of the applicability, so how we apply a research study to the patient in front of us, is that physician experience part of that triad. And so I want to speak to that super briefly. So when you do a randomized trial, it's very important that the population is very homogeneous, right? So that you're really only measuring the difference that you see is really due to the intervention. So that's important mechanistically and methodologically. However, it's limiting when you apply it in clinic because your patients never fit those buckets perfectly, right? So, for example, these are post-infectious IBS patients that don't have SIBO in this study, right? Now, personally, so you could very strictly say, well, the way I would look at that, and maybe you look at it differently, the way I would look at it was say the best evidence that we have on this is specific to this population. However, clinically, for example, patients that meet IBS criteria that also have SIBO, especially if there's post-infectious in nature, I do use this, right? Because I feel like it's a reasonable stretch. And a lot of the mechanisms I think are the same, and IBS and SIBO overlap a lot as well. I think the reason they excluded it was to sort of have that clean, this is why people got better. It isn't because of the SIBO per se. But anyway, that's how I would look at that. So that's my application in practice. But a strict interpretation, a strict textualist would say, no, we only use this with people with post-infectious Rome 3 IBSD that do not have SIBO and have leaky gut.
Yeah, I'd agree. Yeah,
Cool.
excellent.
All right, my friend. Well, that was really fun. And keep them coming, listeners. Go ahead and email us study questions, methodology questions, practice questions, philosophical questions, etc. We're trying to line up a neat conversation with a chiropractic colleague on vitalism within integrative medicine, its place or lack thereof in that domain, which I'm very much looking forward to. But I also love going through these studies, Adam. I think this is very useful to our listeners as well. So we'll continue to go back and forth between the big picture questions and the nitty gritty of dissecting research articles.
Yeah. So make sure to reach out to us at Dr. Journal Club on all social media platforms. Make sure to check out the mothership, drjournalclub.com. And we have a lot of, awesome resources there for you guys to check out, and deeper dives into studies that we don't even talk about on the podcast. So make sure you check that out as well.
Awesome. Thanks, everybody. We'll see you next week.
Thank you for listening to the Dr. Journal Club podcast, the show that goes under the hood of evidence-based integrative medicine. We review recent research articles, interview evidence-based medicine thought leaders, and discuss the challenges and opportunities of integrating evidence-based and integrative medicine. Be sure to visit www.drjournalclub.com to learn more.